Good afternoon. In this video clip, I want to demonstrate how to give an IV push medication through a peripheral IV and through a central IV. That's all I'm going to say about that right now. I'll talk more about the differences in those lines when I get over there to the patient. So we're going to assume that there's an order for pantoprazole. And I'm going to use this example because it is an example that you're very likely to see in the hospital setting. Pantoprazole, when you take it out of the Pyxis, comes in a vial, and the vial has powder in it. And the instructions are to mix it with 10 mLs of saline, and pantoprazole can be given over 2 minutes. Okay, so this will be my powdered vial of pantoprazole, and I'm going to prepare that. I have a sterile needle, and I have a solution of saline. Actually, I have 3 salines, okay? One will end up being my pantoprazole, and the others will be for flush. So I open my vial, clean my vial. I like to leave my alcohols just sitting there until I'm actually ready to use it. Then I'm going to open my needle, keeping in mind that the ends have to stay sterile, and attach my needle to my syringe, needle off. This has saline in it, so I'm going to put it in here, put the saline in there, and now this powder is going to get mixed. You don't have to take the needle out, and I happen to know just from experience that this particular medicine really dissolves very easily, so you may not even have to put all 10 of it in to get the medicine to dissolve. And then you're going to draw it back, okay? Okay, get all 10 of your mils in there. This vial may not actually have 10 like it's supposed to, but okay, so this is 10 mils. It has pantoprazole in there. This is a sterile needle. You do have options when it comes to sterile needles. You can engage the safety and be done with it, or you can choose to carefully recap your sterile needle. You're not hurting yourself. If you stick yourself with a sterile needle, I'm going to pat you on the back, we're going to throw everything away, start over, and I'm going to move on with my day. It's very different than if you stick yourself with a contaminated needle. If you stick yourself with a contaminated needle, then we're looking at bloodborne pathogen issues, and that is a no-no. Now, why would anybody want to recap even a sterile needle? I'll tell you why I do it. I've got some arthritis issues in my hands, and over the course of 30 years, you use your hands a lot, and I get a little bit more leverage doing it this way. Just a little bit more leverage. Not a big deal. The other option you have is just to engage the safety on your needle, and now you have a safe needle. You do want to leave that needle on there. I've observed nurses on occasion going ahead and taking this off, and then they leave their medicine exposed like this until they give it to the patient. Well, that really doesn't make a lot of sense, because that could be a little while. By the time you talk to your patient, deal with whatever, and you're holding this in the air, not a good idea. So this does a couple of things. It acts as a cap, keeping your solution sterile. It also identifies this clearly as my medicine, okay? Because now I've got my saline flushes, and I can clearly tell the difference. Saline flushes, medicines. If I had quite a few IV push medications to give my patient, then I might actually break down and take a piece of tape and write on the tape what this medicine is, what that medicine is, so I can keep track. Whatever it is you need to do, you always need to know in the moment what you're putting in a patient. You can't say that, well, one of these syringes is such and such medicine. No, you have to know what is what at the time. So I'm going to take some alcohol with me. I'm going to take my medicine sheet, or whatever it is that I need to identify my patient. I have to have some way of identifying. In the hospital world, we do that with scanning. We scan the medication, up pops the patient, we scan the patient, we make sure that what we've scanned matches what the computer says. We make sure that the patient can identify who they are, their name, their birth date. Just because you scanned it doesn't mean that you don't ask your patient for their name and their birth date. The exception, of course, would be a client who cannot tell you that information because they're cognitively impaired. Then you're going to check their armband visibly. You're going to check their armband visibly anyway. Okay, so I have my medication sheet. I'm taking it to the bedside. And hello, Mr. Washington. How are you today?
Good. How are you?
I've got some medicine to give you. It's pantoprazole. That's to help with acid secretion development in your stomach. We don't want that to be too much. And so, can you give me your name and your birth date?
My name is George Washington. My birth date is 12/11 of 95.
Okay, thank you for that. All right, back to you guys. So I'm going to first show you how I would give this if this were in a peripheral IV. This patient has 2 peripheral IVs, and that's on purpose because I wanted you to see the differences that you might see in the clinical setting. A lot of times the patient comes with an IV that looks just like this. Of course, this is hidden under the skin. And by the way, you know I did hand hygiene, right? Before I ever started any of this, my hands are clean. So this is all under the skin. It's got a dressing on it. I'm looking at it to make sure that there's no redness or swelling. It looks good. The patient doesn't complain, when I'm close to it or touch around there that it bothers him. This little cap is capped right onto the IV. So that's one version that you may see. Another version is, this is your Gelco brand IV. This one over here is an AngioSet IV. And what you see here is this is the part that's under the patient. The catheter is under the patient. It's got wings, and it has tubing. And so, when I address this, you notice I can move this, and I'm not really bothering the IV site. So I kind of like this setup. There is a way to make this Gelco act more like that. There is a tubing attachment. Okay, I'm going to just take this off for a minute for grins, but there is a tubing attachment that can be used that has flexible tubing and a port like this at the end of it. And so if you're starting this IV and you're using this catheter, you should get one of those. Has an end like this but has flexible tubing rather than this. I've just noticed that in the emergency room, this is what they're doing, and so the patient comes up with it looking like this. The downside to this, and you need to be aware of that, is every time you go to access this, you see when I move this, I'm actually moving it at the site. So it can be a little irritating for the patient, especially over time. So be cognizant of that. Don't overly wiggle this. Don't do any more than you need to do what you need to do. So I've looked at it, and it looks good. But is this a patent IV? And the answer to that question is you don't know. What you don't want to do is try to figure that out with medicine. So we flush the peripheral IV with saline to make sure that it's patent. Okay. So I'm going to take my alcohol and I'm going to clean this port, and notice that I'm securing it so it doesn't wiggle a lot, and I clean it around and do a good job. Okay, that'll work. And then in this situation, I like to leave my alcohol between this and the skin. Sometimes this actually does lay on the skin and it touches it. Keeping that alcohol between there helps maintain sterility. Now I have my medicine and I have my saline. All of these have a little air bubble in them. That's just how they come. And I have found the best way to deal with that is to pull the syringe down a little bit and then forward. That breaks the seal. If you just go forward with it, you might hit the ceiling. It's not the end of the world if you hit the ceiling with the saline, but the patient might jump. All right, so saline's ready to go. Now to assess for patency, you want to inject with 2 or 3 mils, okay? Inject with 2 to 3 mils, okay? Now I'm going to stop because, this is going in the patient's bed for real. And now I'm going to disconnect. I've still got my alcohol under there, so that's keeping it patent, okay? Now this is me. See this needle? I'm going to twist it off, and I'm going to put it over here, keeping that capped off and sterile, so I can use that again. Keep that close. Take my medicine, attach it, and now I'm going to inject this medicine over the prescribed amount of time. I'm either going to look at the watch on my hand, or I'm going to look at the clock that's in the room, and I'm going to time this IV push medication. In the meantime, I might chat with my patient because I can kind of keep track of the time and see how things have been going for my patient, use that for developing some rapport, for identifying some needs, for doing some teaching about something, and before you know it, my medicine is infused. So at this point, I'm going to disconnect this, and I don't really care about this syringe anymore. It doesn't have to stay sterile. My saline does. Now my alcohol kind of fell away, so when my alcohol falls away, I'm kind of obligated to hold this so it doesn't touch the skin. So whatever it is, however it is you need to make that happen. Notice I'm hanging on to the needle because I really don't want to lose that in the patient's bed. Okay, and then flush it again with another 2 to 3 mils. It's okay if you use the whole whatever's left of saline. Okay, saline doesn't have to be measured. Now, one of the things that I like to do is as I'm taking this off, you see my thumb thing is on there. As I'm taking it off, I squirt some saline in it under pressure. And I'll try to explain why. This little cap here has an accordion-like thing in it. And when you put the needle on it, you push that accordion down. Let's see if you can see that. You see how the accordion gets squished together when that goes down? And then when you take it off, it kind of expands. Well, that seals this. But in the process of sealing that, it creates a little bit of a suction. And sometimes you can get blood that comes back into the catheter underneath the skin and you don't see it. But that could clot off. So that's why I like that little technique. Okay, I don't know that all nurses do that, but on my way out, I just kind of keep a little pressure on the saline. And that kind of takes the place of a clamp, because this thing doesn't have a clamp. Okay, now, you've gotten your medicine, sir, and I'm going to go about and do a few things, and I'll check on you later. All right, so that's that. So let me show you what would be different if I was using this other IV setup over here. Like I said, the one that I prefer. Now, first of all, I would probably go to the other side of the bed, but for purposes of videotaping, I'm just going to stay where I'm at. I can reach things pretty well. All right, so here, and again, let's just start with, this is the medicine I prepared. This is my saline flush that's sterile and hasn't been opened yet. Of course it hasn't, okay? So I'm going to clean this port. Notice I can move this. It's really much easier to deal with this one, and I'm not messing with the IV. So I clean that. And then also, I have to flush, and I have to protect, I don't want this to fall against the patient's hand to get contaminated. So I have to find a way to unscrew that, connect it here. Now this thing has a clamp on it. So now I'm going to unclamp. And honestly, I could have unclamped a minute ago, would have been all right. I'm going to inject with 2 to 3 mils to make sure that it's patent. And then I'm just going to lay that down. It's not going anywhere, and it's not pulling on the patient. See, moving this? No pull on the IV. Now I have my IV medication, so I'm going to unscrew the IV medication. If I want to use this saline again, which I can because this is a peripheral line and I don't need very much, you just have to have the manual dexterity to figure out how to transition that way. Attach this one. Now I'm going to give this over the prescribed amount of minutes, 2 minutes. Again, I'm going to check with my patient and see how they're going, how things are doing, whatever. Watch the clock. Okay, and in 2 minutes that medication is infused. I can lay it down. I can get my saline. Now this doesn't, no, I got to think a minute. Okay. Yeah, this is my final flush. Okay, my final flush. Now this is where it's a little bit different. With this one, I don't worry about that positive pressure thing because before I take this off, I'm going to clamp this. Now when I take this off, you'll see the same accordion motion. Okay, same accordion motion when I take this off. But this clamp stops it from sucking blood into the catheter. So clamp first. So the steps are unclamp, flush, give your medicine, flush, clamp, disconnect. Okay? All right, let's do this scenario again. I have 2 saline flushes, white caps. I have the medication that I prepared. It has the needle on it. And now I'm going to give this medication through a central line. A couple things about central lines. Generally speaking,